All right, let's get rolling here. So, can you hear me? All right. Um, this morning, we're going to go through a lecture about some Adv Perio stuff. And you haven't had this lecture before, I'm assuming, right? No, I haven't given you this before. You probably remember. Okay. I've given it a couple times, and they've with the curriculum changing a little bit and things. I just want to make sure that like this wasn't going to be super boring, that you've had it before, but it sounds like we're good. So we'll go through this, and then at the end, Dr. Hegde asked me just to run through some of those practice questions. She said a few people had a few questions, so we'll just, if you have any questions about any of those, we'll run through that and talk about that. So we'll start with the lecture, and then we'll go to the questions and just run through those next. So let's start this thing. So today we're going to talk a little bit about Adv Perio and Adv Perio lesions and how those kind of interact and work together. So I'll start with this. This topic sometimes can be a little confusing because there's a lot going on both with the endo and the perio in some of these things. And what I want you to get from this is there's a few basic things, and we'll kind of emphasize those as we go. But just try to understand that this is complicated, first off. And some of it is, just trying to put names to things that we may see in our practice or when we work on patients. And this isn't. I don't want you to get caught up on little tiny details. That I want to have you more understand the concepts and some strategies as far as if you feel like you're dealing with this, what do we do and how do we move forward? So you've already seen all this stuff. So this is just kind of a little overview of what we're going to go through. So we'll start out just by talking about the pulp of the tooth and the periodontium and how they are connected and intercommunicate and how they influence each other in both health, in health and also in disease. So we'll spend some time here in the next few minutes talking about the connection between the pulp and the periodontium. We'll spend a little bit of time on microbiology, just like bacteria and things that might be going on in some of these lesions and some of these problems. And then we'll go through the classification of combined endo-perio lesions and how do we classify them and treat them. And then there's a couple other things at the end that we'll talk about with concerns about endo-perio. So this is kind of where we'll start and kind of where we're going to go. And then, like I said, at the end, we'll run through some of those questions so that we can make sure we understand what's going on there. So we know that there are connections between the pulp and the periodontium. We can see these through microscopic examination, through cone beam, and lots of other different ways. But they're connected anatomically with vascular connections. So we know, and we've seen that if when the pulp is insulted, so someone has a fracture in a tooth or they have caries that reaches the pulp and they get a endo problem, that products from this process may end up or even influence. Oh, going back. Sorry. May influence the periodontium, and this causes an inflammatory response. I mean, you can see this when someone has an apical lesion from endo, right? That lesion is in the periodontium. That's in the bone around the tooth. It's affected the PDL. Sorry, the Zoom thing. Hang on, I got to do something real quick. I got to push this down here. There we go. Okay. The screen for Zoom like covers the side of my screen, and I can't see what we're talking about. Sorry. All right, that's better. So we know that happens because we can see it when we look at a radiograph when someone has an endo problem that, and that's typically out of the apex of the tooth, right? But occasionally we can see that from like a lateral canal, and we'll talk about that in just a second. But periodontal disease, on the other hand, is typically a little slower acting, right, than endo. The lesion, in most cases, doesn't progress as quickly. But if that lesion is allowed to progress to the point where it reaches the apex of the tooth, that periodontal lesion can affect changes in the pulp. If it reaches that apex and the foramen at the apex of the root, then you can start to see pulpal changes. Or occasionally, if there's a lateral canal, that may cause problems in the pulp as the periodontal lesion progresses. So these things affect each other back and forth, and there's definitely some sort of connection that happens there. So we know that between the pulp and the periodontium, we have lots of different, we have neural pathways, lateral canals. We have our dental tubules, which cause people to have sensitivity if the root becomes exposed. The PDL, bone, apical foramina, all of these things are connected between this tooth and the pulp and the periodontium, and it's a fairly intimate connection. They're communicating with each other, and things are passing through and going in and out there. The most interconnected evidence and the relationship that we have, the most relationship is vasculature. So apical foramen, which all teeth have. So that vascular bundle that passes into the tooth is going through the periodontium into the pulp. You have lateral canals, which act as like apical foramen, but smaller and typically on the sides of the tooth, or even dentinal tubules, which we talked about. So you have these tubules in the dentin, which communicate into the periodontal space. And, we see that a lot when we have recession and those tubules become exposed, then that can communicate with that nerve in the tooth and cause sensitivity, whether it be to cold or air or sweets or whatever the case may be for a patient. So again, just keep in mind as we go through this, there's connections here. It's not like there's just some isolated. These are both just isolated tissues. Okay. Now, the extent of that connection can be questioned at sometimes, but there is some sort of connection there between these two tissues and these two areas around the teeth. Another connection between the two are furcation canals. So a furcation canal is typically found in a molar or a tooth with a furcation, and it goes into that interradicular area. And so this study by Hargreaves, this paper kind of was a review of some of these things, but they put in a little table here of incidence of furcation canals, all these different studies that looked at them. And so it's quite common that they found these. And there's different ways to do this, right? So they, some of them sectioned a tooth, others did dyes. Some looked at it under a microscope to try and find these small canals that go into the furcation. So these are furcation canals are there. Do they always cause a problem? That's questionable. But again, the point of this slide and this discussion is just to show that there is communication between pulp and periodontium. So there's information, there's blood, there's nerve that passes through these areas and connect the two. A couple other, we'll kind of run through some of these. So accessory canals. So accessory canals are canals that exit the tooth not in the apical foramen. Okay, so it's they can be common. This study by Rubach found that there were 33 of 74 periodontally extracted teeth had accessory canals. Most of these canals, if you find them, are going to be at the apical third of the root. So typically it's going to be pretty low on the root, which means, you're going to have some pretty serious periodontal involvement if that's going to affect that. But they're there again. Dentinal tubules, like we kind of talked about. you can get communication to the pulp and the periodontium, especially with sensitivity. Typically, this we see this can happen even more when cementum is denuded. So if we root plane something and remove some of the cementum and expose some of those tubules, that can cause some interaction there. And then finally, you can see on the picture there an example of a palatal gingival groove. So that's a groove in the enamel and cementum and dentin that runs apically and may actually go to the apex. So this is something, if you look for it, you may see this on some of your patients where they've got these grooves. Typically, you see it mostly on, most commonly on a lateral incisor on the maxilla. And you'll see that groove running down the root of the tooth. And that can cause an issue because, number one, it can become difficult to clean. And you can have calculus and bacteria kind of aggregate there and move down the tooth, almost like a furcation, where it's just kind of hard to cover or clean. And if it, as you see here in some of those patients, a small percent actually reported that groove going to the apex of the tooth. So if something starts to affect that groove, it can make its way all the way down to the apex of the root and then start to cause some issues endodontically for you. So again, these are just some examples of how are the pulp and the periodontium connected. A root perforation obviously would cause some communication, okay, and that's typically what we call iatrogenic, right? So something that we do that causes a problem. So we're doing a root canal, right? Or we're trying to do a post, and we start to prep and kind of get off axis and perf the root. So that's obviously going to cause some communication between the periodontium and the pulp. These perforations can be a problem, especially the further apical they are, because that makes it really hard to seal and repair when we see that. And you can see in the photo here that there's a lesion developing right around where that perforation happened. And so, if it's more coronal and we can access it and try and repair it, occasionally we can do that, but that can be a real challenge in saving a tooth when we have perforation like that. Again, you may also have cracks or fractures of a tooth. So if you were to see that, that'd be a means of communication pathologically between the pulp and the periodontium. Okay, let's keep moving here. So now we're going to talk a little bit about the influence of pulp pathology on the periodontium. So we know that when we have a problem in the pulp, so we have some sort of infection or insult to the pulp, we can begin to see necrosis of the pulp and of that tissue. And that's going to lead to byproducts, so debris, dead cellular material, bacteria, their byproducts and other irritants, typically moving apical, right? So we typically see a lesion at the apex of the tooth radiographically that's occurring as this pulp degenerates. These factors can lead to periodontal tissue destruction. So tissue is being destroyed as we see that lesion, and that's periodontal tissue. That's tissue around the tooth. And it can cause some retrograde periodontitis, meaning periodontitis, rather than starting from the coronal where the gingiva is, starts more towards the apical and moves upwards. So an untreated endodontic lesion may be a risk factor for this type of periodontitis, okay? And we'll kind of go through some of that when we talk about the classifications, okay? The nature and extent of this destruction depends on a lot of different factors. So what's the virulence of the bacteria that's causing the endodontic lesion? Is it more or less aggressive? Is it more or less virulent? Um, uh, how long have they had it, right? So the longer they have the disease, the more likely it is that that's going to become more destructive, and that lesion's going to grow and cause more destruction. And how effective is the host, the patient, at fighting infection? So if they're a little bit immunocompromised, are they going to see a worse outcome, or are they, a little bit more adapted to fight off this type of infection? So essentially what we're seeing here is untreated or long-standing endo can cause some destruction to the periodontium and even lead to some sort of retrograde periodontitis. So the periodontium's ability to this slide is basically just, I put this in here because I wanted to show, there's couple things. Number one, this slide we're talking about, if someone has endo, okay, if they've had endodontic treatment, and then that tooth loses attachment, can we go in and do periodontal treatment on that tooth and expect to see some regeneration? So the tooth is itself essentially treated, so the nerve was necrotic or irreversible pulpitis. We go in, we do that treatment. Can we then expect to see like resolution in periodontal attachment loss? And if there's some bone loss, can we do some grafting like on a defect? So that's what we're going to talk about here. But the other point I want to make on this is kind of a more broad point in literature and in dental treatment is, you can find in the literature lots of different ways to support an argument, and a lot of times you can find literature to support the counter argument. So that's what I put this slide in here just to kind of talk about a few things and just show that there's differing opinions on a lot of things, and especially this topic with Adv Perio, there's you can go a lot of different ways with how you want to treat it and how you want to approach it, and what we want to end up with. So again, in this 1983 study by Sanders, they found that teeth that had been treated with a root canal did not respond as well as untreated teeth to regeneration. So on a non-treated tooth, so a healthy pulpal tooth, they had more osseous regeneration than on teeth that were treated. However, in this 2001 study, they found that there was no effect on their treatment versus on a root canal treated tooth versus a healthy tooth. And then again, most of the studies you'll see find that pulpal status really doesn't have any effect on regeneration. However, like I said, I'm just putting this in here just to show you that there is some disagreement in the literature. However, my opinion and what I've seen is if a tooth has had a root canal, as long as that root canal is done well and the tooth is free of any pulpal pathology at the time, we can do good periodontal treatment on that tooth and keep it. But again, I want you to see that there's disagreement in some of these things and can be kind of confusing. But that's where we want to be critical thinkers, and we'll have our own experiences as well. But again, most of the literature that I've seen and in my experience, if a tooth has had pulpal pathology but it's been treated well, we can do periodontal treatment and have success on it. And then, this Hargreaves study is saying that endodontic lesions, there is some correlation with deeper pockets and furcation involvement in mandibular molars. However, the causal relationships have yet to be established, meaning there is a correlation. So we see, like, if a tooth has an endodontic lesion, it may have, it's likely to be associated with deeper pockets and furcation involvement. However, there's no evidence to say that because it has an endodontic lesion, it's causing it to have deeper pockets. Okay, so in my mind, what I think here is, number one, yeah, I may see some deeper probing depths, but that doesn't mean that because it has an endo issue, it's causing deeper pockets. But then I think, a lot of times if we're seeing endo lesions, maybe this patient's hygiene isn't the best, and that's why we're in the endo, and therefore now we have some perio. Does that make sense? So you cannot, there's no evidence right now to say that endo, just because you have endo, means and leads to deeper pockets. However, if you have endo, you're likelier to have deeper pockets. Okay. So now we're going to switch gears a little bit and go the opposite way. So we're going to talk a little bit about the influence of periodontal inflammation on the pulp of the tooth. So there is evidence that clinically advanced periodontitis, meaning stage 3 periodontitis, stage 4, or severe form of the disease, can produce pulpal necrosis if it reaches the apical foramen. That is not always 100%, but there is evidence that that can happen if the periodontal disease reaches that extent. Pulpitis and pulp necrosis have been shown to occur if that inflammation reaches an accessory canal. So we talked about the decent percentage of teeth have accessory canals. Typically, they're located in the apical third of the tooth. And so if that periodontitis reaches an accessory canal, there's a chance that exposure of that canal could lead to pulpitis and even necrosis in a tooth. That response can be affected by our treatment even. So if we go in there and we're not going to necessarily see an accessory canal on a PA or something like that, but we go in and we start to scale and root plane this tooth, or we flap it and debride the area. If we're debriding away at an accessory canal, then we can cause some damage to the pulp of that tooth. This is and we put this in here because there's some evidence of this. This is not something that occurs regularly or happens all the time. Okay. In fact, I don't know that I've ever had it in my experience happen where I've done some treatment and it wasn't like, it's not down into the apex of the tooth, but it's deep and we're cleaning, and then they have a pulpal problem. Okay. So there is it can happen, but it's not very common. And it's not something that I, every time I do a surgery, that I worry about. Okay. Obviously I'm a little aware of it. It's in the back of my mind, but it's not something that stops me from doing treatment, that, hey, there might be an accessory canal here. That doesn't necessarily influence my treatment plan, but it's something that if I were to do some treatment and then, later they're having an issue, then I start to think about, maybe this is what's going on and why we're having this issue. Typically, these inflammatory, the pulpal lesions are found in teeth with larger canals, and the disease has reached, the periodontal disease has reached the apex. So you're more likely to see this in someone that has really severe disease and that lesion, that periodontal lesion, reaches down around the apex of the tooth, and they have a real big, large canal, and that's then caused some necrosis. Okay, at that point, the prognosis of the tooth is not very good if you've lost that much bone, and you will likely need to look at other treatment modalities than trying to save that tooth. I will tell patients, I will inform them of this if say we have a tooth that has a really advanced lesion, patient doesn't want to lose the tooth, they want to try something and try and keep it, and so we're going to do like a surgery and clean down there. I do make them aware that, hey, this is near the nerve of the tooth, and there's a chance that us doing this may, there may be some effect on the pulp of the tooth, which could lead to some other issues like root canal and things like that. So I do inform the patient that this is close to the nerve, and sometimes there's some communication and some crossover there. But again, it's as far as like accessory canals and things, I'm not normally, that's a pretty rare thing to have happen if it's going to be affecting the periodontium versus the pulp. So the cementum of the tooth, so we know that's the tissue found mostly on the root. Cementum actually appears to be an important protection for the pulp from the periodontium. This study by Lindy and Bergenholtz found that 70% of periodontally involved teeth, so this is 30 to 40% of attachment loss. So that's a decent amount, moderate to severe amount of attachment loss. Showed no pathologic pulpal changes. So the majority of the teeth that they studied that were extracted, for periodontal reasons, showed no pulpal changes. Okay. However, there was some 30% that showed small pulpal changes. So this is an animal study. I think it was may have been beagles, but they induced periodontitis. They extracted the teeth and looked at the pulp. So about a little less than a third, showed some small pulpal changes. Typically, those changes were associated with root resorption. So meaning cementum was lost on the tooth, and therefore then dentin and tubules were exposed, and that irritation could occur. So if what their outcome or what their point being is if we have cementum on the tooth, then typically that's a good protection of the dentin and the tubules underneath. So if the cementum's present, then typically we don't see much of an insult to the pulp. So that's something to keep in mind in any case when we're cleaning or root planing. We don't have to be so aggressive as to denude the root of all cementum, right? We want to remove the calculus and the bacteria, and obviously we remove some cementum as we plane. And typically, if it's in a tooth that has periodontitis, we're removing some diseased cementum, but we don't have to remove every single piece of cementum. It's good to keep some of that and have that as a protection of the root and the dentin and tubules.
Dr. Jensen?
Yes.
Cementum regenerate?
Yes, we can regenerate cementum. That typically happens from cementoblasts. Okay. Let's see. But yes, you can regenerate cementum. But if you totally denude the root surface of cementum, it's going to be a lot harder to regenerate.
Okay.
Okay. So periodontal lesions, okay, as they progress down the root, there is some evidence that they may disrupt nutritional supply of the pulpal cells via these accessory canals. So what they're saying here is that as there's a chance that as periodontitis progresses, as it moves down the root, as it affects the root surface of the tooth, occasionally it can cause some necrosis of these accessory canals, which then disrupts some of the nutritional supply of the pulpal cells. Now, keep in mind, the main source of nutrition for the pulp and nerve of the tooth is through the apical foramen, through that major vascular bundle. So again, this is an older study done a long time ago. Other studies have failed to confirm this a direct correlation between periodontal disease and pulpal changes. Um, and what they're saying in the second bullet point essentially is that there's not a lot of evidence that if an accessory canal happens to be present and you have it exposed in periodontal disease, the pulp typically does well as far as not degenerating, as long as that main canal is not involved. So like I was saying, the majority of the nutrition and the blood flow of the pulp happens at the main apical canal, not an accessory canal. So as long as that main canal is unaffected, typically your changes are going to be small to none. But you could have some, you may see some changes if an accessory canal is affected, but they would probably most likely be minimal. So in general, the takeaway point here is that the pulp is capable of withstanding physiologic insults induced by periodontal disease in most cases. If that periodontal disease reaches the apex of the tooth, then you have a little bit higher chance of having some issues pulpally as influenced by the periodontium. So a little bit of microbiology. We won't spend a ton of time on this. There have been some studies that have taken samples, bacterial samples of both of endodontic and periodontal abscesses, and tried to look and compare between the two what differences may be in the microbiology of these two lesions. So in this study, they found that spirochetes are found more abundantly in periodontal lesions, which if you've seen some of the literature on that makes sense. Spirochetes are typically more associated with periodontal disease than other diseases in the mouth, whereas an endodontic lesion tended to have more coxoidal lesions. So that kind of makes sense too, because that's typically what we think of with like caries and things. And so we expect to see some of that. However, some of these coxoidal species were found in 25 to 40% of both endodontic and periodontal lesions. So they do share some microbiology, it appears. However, there are some differences, mainly a higher percentage of spirochetes in periodontal lesions, and typically higher percentage of coxoidal species in an endodontic lesion. There have been some similarities found between endodontic and advanced periodontal infections, and that's just a list of some of those bacteria. I don't think there's going to be like a question on specific bacteria, but there it is for your information if you are interested. So the point of this slide is that there are differences between the two. However, they do overlap on a few things. Mainly spirochetes in a periodontal lesion are more common. So let's talk a little bit about these combined lesions. So there is a classification of lesions, okay, of Adv Perio. Okay, so we have what's called a primary endodontic lesion. So that would be your classic endodontic lesion. You have insult to the pulp, and then you start to see that periapical radiolucency around the apex of the tooth. You have a primary endodontic lesion with a secondary periodontal lesion. Okay, and we'll talk about that. Your primary periodontal lesion, so we see attachment loss and bone loss around the tooth. And then you have that primary periodontal lesion with secondary endo, and then a true combined lesion. So we'll take a few minutes here and work through these. Okay. So this is just a little picture of these things. So On the left, you can see a primary endodontic lesion. So you've got, the left root of that molar, essentially the lesion coming out the apex of the tooth. So primary endo. Next to that, you have primary endo and secondary perio. So you have endo starting first, and then sometimes, we'll see that either drain up through the periodontium, or in this case, it's showing again an accessory canal causing some periodontal tissue loss. Again, primary perio on the right side of that center tooth. You've got calculus and attachment loss starting from the coronal aspect, and then you have a primary perio, secondary endo. So that's essentially, perio. It progresses to the point where it starts to affect the pulp, and then true combined perio and endo lesion is where you have a primary endo, so some sort of root or canal necrosis, but there's also perio, and they actually meet together and meld. And then a concomitant endoperio just means those haven't met yet. So you have perio going on with an endo lesion, but they're not connected. And we'll go through this here in just a second. So this is just kind of a little overview of these different lesions. So a primary endo lesion, okay? Typically, we see these lesions begin to resorb bone apically and laterally. Typically, it's a non-vital tooth, okay? So we do endo testing, and the tooth is necrotic, so no response to cold, nothing to our EPT. It may be painful on percussion and palpation. You may even see some increased mobility on these teeth due to the inflammation, and you may see some swelling on the marginal gingiva. You may notice a sinus tract through the PDL, and occasionally this manifests as a deep probing depth with drainage. However, that's not always found. And the treatment for this, obviously, is a non-surgical root canal. So this is a classic case of patient comes in, they've got caries or whatever, and it's to the pulp. It hurt them for a little while. Now it doesn't hurt. You do your testing, necrotic, boom, we're going to do a root canal. That's the treatment here, followed by whatever restorative may be needed. So a primary perio or endo lesion with secondary perio. So typically this is seen as with an endo lesion that's gone untreated for a long period of time. And so as without that treatment, that tissue destruction continues on, and you see more and more tissue destruction, more and more tissue loss. Eventually this leads to drainage through the sulcus, and then you start to see plaque and calculus accumulation, and periodontal disease develops. So the one thing that's different here is in that primary endo lesion, right? We just said sometimes you have a deep probing depth, okay? That's from the drainage of the lesion, okay? And that typically resolves on its own with treatment, okay? So on that sinus tract through the PDL manifesting as localized deep probing depth, there's no calculus, there's no bacteria like building up there. It's just essentially just a draining sinus tract. Once treatment happens, it goes away, okay? On a primary endo, secondary perio, you see that tissue destruction, but then on top of that, because of that destruction, because of that loss of attachment from like a sinus tract, now you have calculus and plaque accumulating in that area and causing more destruction. So this is more than simply just a draining sinus tract. This is something that's been there for a long period of time, and now you're seeing calculus and plaque build up in these pockets in these areas, causing more attachment loss. Okay, does that make sense? Does that differentiation make sense? Okay, so in this case, again, you're treating the tooth, you're testing the tooth. This tooth has pulp necrosis. Okay, so the tooth is necrotic. But there's also plaque and calculus, and you're probing deeper probing depths and having attachment loss, right? So this is combined. Okay, this is something that started with endo, but then because it went a long time without treatment, you started to see buildup of tartar and calculus and bacteria, and that led to even more loss of attachment, and you have endo and perio happening. But it started with an endo lesion. So in this case, the treatment here is first we do our root canal, and then we debride the periodontal pocket. So your first treatment here is get the endo done, and then treat the tooth periodontally. Okay. And we'll at the end we'll talk about these are, it's hard, some of this stuff is just we just want to have a label for things, right? We just want to have a classification so that we can say things. If this came into your office, it would be really hard, unless you had a long record of this patient, to determine what happened first, right? Like, who knows if it was a primary endo or a primary perio, or unless you can really watch it over time. But I don't want that to distract you from how we treat it, because that's going to be the most important part. And you'll see a pattern here is how to treat these lesions. But these are things to just keep in mind as we talk about this. So primary perio. So this is kind of what we've been going through all along. It's a progressive process. It's an inflammatory process, and it leads to bone loss around the tooth. Typically, we see plaque and calculus accumulate. And the sulcus depth and loss of attachment increases over time. So, that calculus begins to move down the root of the tooth. As it moves, more tissue destruction, more loss of attachment, more loss of support on the tooth. Eventually, we typically see mobility of the tooth. However, the big difference here is this tooth tests vital. So if I were to test this tooth, pulp test is normal. So if you look at that X-ray on the right, there's bone loss all the way down around the apex, but that tooth is still testing vital. So again, this is just proof that just because the perio breaches the apex doesn't mean it's always going to devitalize the tooth or affect the pulp. Okay, there's a chance, but it may not. But this is, again, a vital tooth. So not endo, this is primary perio. Typically, probing depths are broad base, and plaque and calculus are noted. So like between this and that primary endo, if you have that draining fistula, that's typically a really thin, narrow probing depth. Okay, so it's just enough for the stuff for the infection to drain. On the perio case, typically your probing depths are going to be wider and broad. So treatment here is obviously scale and root plane, debride, possibly periodontal surgery. So primary perio.
Dr. Jensen.
Yep.
Can you, clinically speaking, what is the difference are you feeling with a broad-based probing depth versus a narrow one? Yeah.
So that's a good question, and I'm going to do my best to explain it. So like to me, a narrow probing depth is, as we probe, we tend to walk our probe around. That's how I do it. I kind of, move it around at small intervals, right? Typically, a narrow probing depth to me is, as I move, I drop down into a deep depth, but I almost immediately start to come right back up as I keep going around the tooth. Does that make sense? So I'm walking my probe, I drop in, then I come right back up. Whereas a broad depth would be like I'm probing, I drop down, and I just I keep probing. It's more than a millimeter long or distance before I start coming up again. So like on an interproximal area, like I'm probing deep both on the buccal and the lingual, and it's broad through that space. It's it's easier to feel it, right? But a narrow probing depth is, I can probe relatively normal probing right alongside where that deeper depth is.
Okay.
Does that make sense? It's hard to explain without feeling it, but
yeah. So are you saying because we typically chart out 3 numbers per
Right.
buccal or lingual. So are you saying that a broad one's going to extend? You might have a 5 next to a 5 on the straight. That would be broad, or are you saying it could be even narrower than that? You could have a 5 on the distal, but it could be broad or narrow.
It could be.
Okay.
But when I probe, I don't just probe in 3 areas. Like I'm not just like sticking in it, stick it here once, twice, 3 times. I probe and then I keep probing and walking my probe along the tooth. Because like, that middle probing depth, it doesn't mean just like right in the middle of the tooth. It could be a little bit to the mesial or to the distal, right? It should be how I do it is the deepest spot in that area. Does that make sense?
Right. Yeah. That's what we do. I'm just saying for charting purposes, we only chart down 3 numbers.
Right. Yeah. Me too. But I'm trying to feel that, and like a broad probing depth to me is like, there's more than a millimeter of width of that probing depth. Like I walk my probe, I drop right in, and then I come right back out. That's narrow. That makes sense?
Yeah.
Yeah. Okay. Sorry. That's like me. You just see me like, if someone was watching this, they'd think I was like dropping salt on something or whatever. But no, just it's kind of like it's definitely subjective, right? Like that's a subjective. I don't have like a number to tell you, but with experience you kind of can feel the difference between narrow versus broad. But that's how I do it.
All right, thank you.
Yep. Okay, so primary perio, secondary endo. Okay, so this is similar to the primary endodontic lesion. However, in this case, the periodontal lesion develops first. So you have deep pocketing with extensive periodontal history. So, this patient has had perio. They've been in your office. You've seen them. You've treated them. They still have some deep pocketing that you're maintaining, but eventually the patient starts to complain of pulpal pain. So they develop some pulpal pathology. Now, this is typically not necessarily related to the periodontal lesion. However, they have perio first. Okay, so again, remember there's a lot of semantics here. Okay, like what came first, the chicken or the egg kind of thing. So this is a patient that had perio before, and they're being treated for it or maintained, but now they've developed a pulpal pathology on the tooth. So they start to complain of pulp pain, and you test them, and the tooth either tests, non-vital or necrotic or irreversible pulpitis, and they need pulpal therapy. So again, just note that the treatment here, same as the primary endo, secondary perio. We do our root canal therapy first, and then we periodontally debride the pocket again. And if it needs perio surgery, we do that as indicated. Okay, so primary perio, secondary endo. We got perio first. We've had perio. We have an endodontic problem develop. We're going to treat the endo first and then debride the perio. Okay, so that's the same treatment as a primary endo, secondary perio. Okay, and that's kind of like the take home that we want to have here.
Dr. Denson, I have a question about that one. So if we have endo lesion and a perio lesion, I want to see if I'm understanding this correctly. If you want to differentiate if it's primary perio or primary endo, is that based off the pocketing? So if you have like a narrow pocket, can you assume it's a endo is primary? And if you have a wider pocket, can you assume that it was the perio that was primary?
Yeah, so that's a good question. So what I would say to that, so if everything's healthy in general, right? You don't have any perio to begin with, and they develop an endodontic lesion, and then you have that one narrow probing depth, but that's likely like drainage from the endo. Okay, I'm not going to necessarily consider that perio. So I should be able to treat the endo and have that resolve, that draining fistula, right? So
Yeah.
with primary endo, secondary perio, this is a lesion that, has been there for a while. And now they actually have what I consider perio around that tooth, meaning there's broader, deeper probing depths, there's calculus and bacteria present, and it's something that I have to debride. Like a draining fistula on just primary endo, I don't have to, there's no calculus there. I don't have to clean that. You could irrigate it or whatever if you feel like there's some infection in there, but essentially when the endo is treated, that fistula should heal and reattach. Okay. Does that make sense?
Yeah, but I was thinking, what if like the fistula is on like the buccal side of that pocket, and you kind of have a more generalized pocket, but only on the buccal? I was wondering if you would see something like that in a primary endo, secondary perio lesion, and then in a primary perio, I'm wondering if you just have pocketing all around the tooth, and then just like an endo lesion that develops from that.
Yeah. So yeah, essentially those are similar, right? Like almost the same. So this what with this primary perio, secondary endo, this doesn't mean that this isn't saying that perio caused the endo. This is just saying that you had a tooth that has perio that developed an endodontic lesion. So it doesn't mean that perio caused the endo. It just means that this tooth has two lesions, but the perio developed first.
Okay, I see.
Does that make sense?
Yeah, it does. Yeah, thanks.
And so we're going to talk about next, like a true combined lesion, and that may be a case where you have perio that causes endo, or vice versa.
Okay,
but that means that the lesions are connected. So it's kind of like I said, this can be kind of confusing. Whereas like I don't want I just struggle to I don't want you to get caught up on that stuff, because what I want you to understand, the main thing here is we need to determine if there is endo needed, and typically endo is what we treat first, and then we treat the perio. That's kind of what I want this take home to be. So here's the true combined lesion. So this occurs when you have an endodontic lesion and a periodontal lesion coalesce. So they both developed, and now they've come together and met together. So the lesion essentially becomes indistinguishable from one another, those lesions, okay? So you have pulpal necrosis, or it could be like a failing endo. But then you also have plaque, calculus, and periodontitis in various degrees on that tooth, and possibly teeth around it. In most cases, a lesion like this has a poor prognosis, because you've lost typically a lot of tissue around the tooth, and you will have a hard time treating that. However, so the treatment here on these teeth would be number one, could be extraction. That may be what you're looking at. But again, if you feel like if it's a treatable tooth and something that you can save, we do our endo first, and then we do our periodontal treatment, whether that be debridement or surgery. So what you're seeing here on the right side on that x-ray is number 20 is necrotic, okay? But it also has probing depth to the apex. So you have this periodontal lesion and endodontic lesion that are essentially one lesion now, but you have a necrotic pulp. So you have to have a pulpal diagnosis to have a true combined lesion. Whereas remember, we looked at this slide, that canine has a vital pulp. So this is therefore a periodontal lesion. So does that make sense? I know that, again, like there's a lot of semantics here, but essentially, what determines whether it's a primary or a secondary is what pathology occurred first, whether it be the endo or the perio. Again, your treatments are typically going to be endo first, then treat perio. Okay. If you feel like that's if it does have an endodiagnosis. If it's just perio, then obviously we're going to treat the perio. Okay. But I want you to just remember that part. Now, the challenge with these, like if you see something like this in your office or whatever, unless you have like a long-term record of the patient, it can be really hard to tell what came first, like, right? Like chicken and the egg stuff. But just remember that your treatment is going to be basically the same, whether it was the perio first or the endo first. We're going to do the endo and then we're going to treat the perio.
Dr. Jensen?
Yeah.
On that, is the reason you treat the endo first, is it so that you can start getting some resolve in the bone? Because it doesn't take as long for the perio tissues to heal?
Yep. Because, typically that endodontic lesion is causing inflammation, and you can't necessarily reach that just like through perio means. And so, and that's typically also what's causing the patient discomfort, if they're having any, is the endo. And so, we typically treat that first, and then that can resolve some of your problem just by getting that under control. And then the perio can then be cleaned up.
Great.
So,
Yep.
Question.
Yeah.
So the difference, sorry, let me scroll back up. So the difference between just to reiterate again, primary periodontal lesion is that with that, you're going to have a vital pulp, right? Yep. And so the difference between that and a combined lesion would be the necrotic pulp, right?
Yeah. Yep.
Other than that, it pretty much looked the exact same.
Right. A primary a primary perio. I just showed a picture of it going to the apex to prove the point that the tooth's still vital. But that's going to be any sort of perio lesion, just like normal perio. But occasionally it's going to go down around the apex, and you test it and it's vital, then you know it's a periodontal lesion. Does that make sense? Yep.
Yeah.
Question for you about mobility.
Yeah.
In regards to a lot of times in clinic, I have been told by doctors, once you get like a class 3 mobility, the tooth is usually hopeless. In your experience with having teeth that are extremely mobile and then performing some sort of periodontic treatment and getting some sort of decrease?
I tend to normally agree with class 3. If I can depress the tooth, then it's probably time for that tooth to move on. But like with class 2 and stuff, if I can clean and if I can get good access and clean that well, and the patient wants to work with me and do hygiene, typically, you can see some resolution in mobility. Now, does it mean that it's going to be no mobility? No. So we may progress to like class 1 mobile, or even less class 2, and some of that's going to be affected also by like occlusion. So if they're having like occlusal trauma, then you're going to have a harder time too, because that's like, you're going to have to work on their occlusion and change some things there to try and protect those teeth. But it's fairly common to see some tightening up of mobility. Now that doesn't mean, and sometimes that doesn't happen in that first 4 to 6 weeks. Like it can take a little bit longer for that to really solidify. But I find it quite common that the mobility, it decreases. Again, it doesn't always go to 0, and it's not always perfect, but it does improve if things are kept clean. But like class 3, I think normally class 3, I have a conversation with the patient that we probably need to, think about removing this tooth and replacing it.
Awesome. Thank you.
Yep. So this is just a little chart here, like to make a differential diagnosis between pulpal and periodontal disease. So obviously, etiology with pulp, you're going to have infection in the pulp, and you're going to have infection in the periodontium. The big one here is the vitality, right? So we're going to test the vitality of a tooth. So if the tooth is non-vital, then we know there's a pulpal aspect. If it's vital, then it's going to more than likely be periodontal. So restorative, not necessarily related to perio. You could make an argument for like overhangs and things like that, but typically you're going to see like a deep filling or caries on the pulp. Whereas versus the periodontal, you're going to have more of a plaque calculus problem. I don't need to go through all of these really, but the big one there is vitality. I don't think I need to read that all to you. You can read through that, but again, vitality is the big thing to make the differentiation between the two. This is not a very long lecture, so the take home here is, if we're going to determine these things, we have to have a really thorough review of the history of the lesion. So to make a real diagnosis on these, it's really nice to have like a history on the patient. Okay, like I can look through old serial radiographs and see the change in the tooth and the damage of the tooth and what's happened, and then kind of say, okay, it's endoperio or whatever. You don't always have that, right? Like that doesn't always happen. So you may have to be making assumptions. But again, like we talked about, a treatment in these lesions is typically going to be endo first, perio second. It's really important that we get vitality testing on these, okay? Because we have to know whether or not we need to do pulpal therapy on them, and then probing depths help as well to determine the periodontal aspect. Again, when endodontic lesions are present, we treat those typically prior to addressing the periodontal concern, and then a close follow-up is necessary. So we have to have reevaluation to ensure that things resolve and heal. Couple of little other things here as far as some endoperio stuff. So vertical root fractures is something that we see somewhat often. The signs and symptoms are sometimes difficult to distinguish between those associated with perio and endodontic lesions. So typically you have like pain on palpation or percussion. One sign that I typically look for is pain on release after biting. So like I'll use like a tooth sleuth and I'll have them bite, and it doesn't necessarily hurt when they're pushing down, when they're biting, but the moment they release, then they have pain. So that's one sign I'll look for possible fracture. And the idea behind that is when they bite, they're flexing a little bit, and that isn't causing much pain, but when they release, as things retract and move back, that crack moves, they get pain on that. So pain on release typically. But they may have pain on percussion. There may be palpation pain. Again, you can look at the radiograph, and occasionally you'll see what we call that J-shaped lesion. So the lesion on, like if you look at the radiograph there on the right, it extends from the distal down around the apex like a little J. So something to look for on that. That's typically there after the crack's been there for a little while. Okay, it's not necessarily going to happen the first day. You may want to take multiple angles of radiographs to see if you can see a lesion like that. Typically, we've found that these fractures are more common in teeth that have extensive restorations. Okay, they've got big amalgams, or they've got an old crown. Typically, they're a lot of times we'll see a root canal treated tooth, so they've had previous root canal, which can weaken the tooth slightly. Older patients, so that typically just means they've probably had more stress on the teeth. Not necessarily when you turn 70, you're gonna start cracking teeth, but they've just over time had longer stress, longer function, and mandibular posterior teeth seem to be more common with this. There is really no treatment for this, so extraction is the option typically to treat this if it's painful. Again, this is something you may find with a narrow, deep probing depth is a vertical root fracture. So right along where that fracture happens, you start to have attachment loss, and so you're probing along the tooth. Boom, you drop down, and then it comes right back up as you keep moving along the tooth. So another another area where you may see a deep probing depth. Developmental grooves. So we kind of touched on these earlier a little bit. Typically found in the maxillary, central, and lateral incisors. In my experience, it's mostly lateral incisors. They may initiate local periodontal destruction. So like we talked about before, it can be hard to clean that area because it's a little infold of the enamel and dentin and cementum. And if plaque and bacteria start to accumulate there, they can easily start to move down the groove and it's difficult to clean. So I liken this kind of to like a maxillary first premolar with the bifurcated roots, and you have that root groove on the mesial typically, and it can be really hard to clean that if it starts to get exposed, and then it starts to lead to more destruction of the periodontium. The thought on these is that it may have been a genetic attempt to form an accessory canal that never sealed, and so it just kind of invaginated and caused a groove to form on the tooth in development. And again, the big issue on these is patient cleansability. So if they aren't able to keep it clean and you start to see localized attachment loss, then you start to have a problem with these. Typically, the treatment with these is if it starts to lose attachment, you can obviously flap it and clean it. If the groove is pretty shallow, sometimes you can plasty the root and just use a handpiece to remove the groove slightly and try to flatten it a little bit. That may or may not work. But if it's a really deep groove, then it's a little bit too aggressive to try and remove everything. You may be taking away more tooth than you need to.
Would it make sense to put a sealer, kind of like we do with the grooves, on the occlusals of younger patients?
Yep. So that's good. That's a good question. Some people have done that where they'll put like a Gerastor or some sort of like glass ionomer in there. A sealer might be difficult. I haven't done sealing for a very long time. I assume it's some sort of a composite, right?
Yeah, it's super thin resin.
Yeah. So it can be difficult to get attachment to like composite to actually have like it's possible, but it's difficult. But like something with like a glass ionomer or like Gerastor, there's a little bit better evidence for that. And some people have tried that to like varying degrees of success. So that's an option. That's good point. These are just hard. These are hard to treat. Like it's hard to if this starts to have a problem, it can be difficult to really control it. Now, I don't think they don't lose these 100% of the time and they're losing teeth and stuff, but it's just something to remember that as you're doing the exam and you see a groove, if it's a little deeper probing, then hey, we got to really focus on this and keep this clean and that sort of thing. Does that answer your question?
Yeah, it does.
Okay. So lateral periodontal cyst. So these are fairly rare. Typically, it's asymptomatic when they present. However, it's possible that they may have a little pain or swelling of the gingiva. This most commonly occurs in older patients, so 50s, 60s, 70s. It's most commonly seen in the mandibular, canine, and premolar areas. And the presentation on it is lesion, typically mid-root, and hence the name lateral. It's typically to the interproximal space between the teeth. The treatment here is essentially enucleation, so accessing the lesion and removing the tissue. Again, sending it in for a biopsy is going to happen, needs to happen. And most people, if it's a lateral periodontal cyst, if you get in there and clean it out, they heal fine and it's not necessarily an issue for them.
So there's no physical cause for those lateral periodontal cyst?
No, typically it's just a developmental problem. It develops over time. Yeah, trauma could be a cause, but there's not necessarily like a reason. In most cases, you don't know why it happened. It's idiopathic.
Do we, as general practitioners, are we expected to take that out, or do we send that to oral surgeon? What's the standard?
Typically, I mean, that's up to your comfort level. Most people would probably send it to a periodontist or an oral surgeon to enucleate it. Yep. And that, again, if you tested that tooth, it would test vital. So you would know that, okay, this isn't like necessarily endo. I mean, obviously, I guess it could have an endo problem aside from the lateral periodontal cyst, but if it just appeared like that, normal, you would test that tooth, it would be vital. Okay. All right, so this is just a little case just to run through. So my co-resident in Nebraska treated this case. So 72-year-old Caucasian male presents to your clinic. He's got a deep periodontal pocket on tooth number 9 on the mesial. Pocket's been there for 6 months. The dentist scaled and root planed it, but the pocket just came right back. So here's your probing depths. So again, mesial buccal, you got a 9. Buccal is a 6, and then 3s. The mesial and the lingual is a 5, and 4s and 3s. Okay, had some BOP in that area, and so here's a picture. They put in that's a gutta-percha cone just into the pocket to take a radiograph. You can see it goes right up close to the apex of the tooth. Oh, there you go. So there's your sinus tract. So they did their endo testing, and so number 9 did not respond to their EPT. 7, 8, and 10 were normal, and then number 9 was sensitive to percussion and palpation. So number 9 comes back non-vital. So that you start to see and believe that you've got some endo issues, right? Now, just looking at those probing depths. So to me, just as we go back to kind of like the broad probing depth, those are broad probing depths to me. So you've got a deep probing depth, that mesial buccal, but as you move towards the middle of the buccal, it's still a 6. Okay, so that's not jumping right back up to 2s and 3s, right? So to me, that's a broad pocket, and even it wraps around, goes 5 on the mesial lingual. It's not jumping up to 2s and 3s. So to me, as I probe that, to me that's a broad pocket. Just kind of going back to what we talked about earlier. So what they did, she diagnosed it as a primary endo with secondary perio. But again, hard to tell what might have come first because we don't really know, right? However, our treatment's going to be similar. So the treatment was they did a root canal on number 9, and then she did some flap surgery and some cleaning afterwards. And they actually got a pretty good result, and he kept that tooth until we left residency. I don't know where it's at now. Hopefully it's still in his mouth, but no one, I don't know. But it stabilized. So they got the endo done, and then they did the perio treatment. And Dr. Hagday is going to do the review with you. So that's what I've got on that. Any questions on any of that stuff? And then we'll go over some of the questions for those practice questions.
Just related to that case, is endo in the wheelhouse of practice of periodontists, or did she?
No, so
because she's in residency.
No, so she said that Dr. Al-Khatani was our endo resident.
Oh, okay, I see.
Yeah, we don't know. I won't do any endo. You don't want me doing endo. I've done like 3, so, and that was like 10 years ago. So, no, we don't do endo. There are some, actually, you know what? That's funny because there's a guy that went to our residency that did both the endo and the perio residency. So his practice is a perio endo practice, but he's up in Idaho. So,
I have a quick question.
Yep.
Are your lectures from Monday, are the recordings ever going to get posted on to Canvas?
Yeah, they should. I know Dr. Hegde was asking Jackie to do that. So
Okay.
they should get put up there. Yep.
Awesome. Thank
Yep. Okay, let's talk real quick about the questions. Let me pull them up here. So I know Dr. Hegde said she got a couple questions on some of these, and so we'll work through them. And if you have a question on one of them, we'll talk about it. So first one, which of the following does not fall into the category of non-surgical periodontal therapy? So pretty straightforward, right? The gingival graft is a surgery, so that's not going to be non-surgical. Okay, so the other stuff is not considered non-surgical treatment. Which of the following does not normally account for a decrease in probing depth following scaling and root planing? So again, attachment gain through long junctional epithelium is going to shorten your sulcus, right? So that's going to improve your probing depth. And A and C are essentially opposites. So when you see gingival inflammation, that gingiva is going to swell, therefore creating a deeper probing depth, almost through a pseudo pocket or just increased tissue volume, whereas the recession is going to shrink the tissue and essentially lower the probing depth from the coronal. Okay. Root planing results in new attachment through formation of long junctional epithelium. That's true. We talked about that. Typically, if we do root planing or if there's any attachment gain, it's typically through long junctional epithelium in the vast majority of cases. Which of the following describes an aspect of true periodontal regeneration? So remember, with true periodontal regeneration, we have new bone, cementum, PDL, and it's essentially the same as what was there before the disease occurred. So functional collagen fibers inserting into previously diseased root surface would be regeneration. You have new collagen, new PDL inserting into new cementum on the root. The healing of a wound that does not fully restore architecture, that's more like repair in that tissue healing, remember? It's like a scar. And then partial healing with little to no function would not be regeneration. Secondary intention healing, remember, A is the right answer. So essentially, you're not able to reapproximate the edges of your wound. So you're healing through granulation tissue. And B and C are essentially the same thing. We're using sutures to bring the wound margins right together. Which of the following factors does not influence the extent of periodontal therapy? So when we're determining what surgical therapy we should do, remember we are looking at the periodontal chart. So what areas are probing deep or have deep attachment? Are there infurcation involvement that we need to take care of, and attachment measurements? So fracture tooth structure doesn't typically determine periodontal therapy, surgical therapy. That's more of a restorative aspect. So does that make sense on that one? Good.
Dr. Jensen?
Yeah.
I'm going back to the healing one.
Uh-huh.
I just don't remember talking about the primary intention healing. Would you mind just going over primary and secondary real quick?
Yep. So primary intention healing is essentially healing that occurs when we can approximate the tissue wound, the margins of the tissue wound together. So that would be like you make an incision in the gum or a flap, and then that flap is replaced and sutured together right where it was essentially. So the margins of the wound are right next to each other and sutured closed, okay? Whereas a secondary intention healing is where those margins can't be brought together. So there's this space in between them, which then needs to granulate and heal in. So like an example of that would be, if you remember, we talked about the free gingival graft, where we just essentially cut off a square of tissue from the palate, and that wound is just open wound. That just has to granulate in and heal. You can't reapproximate that. So that's secondary intention, is when you can't bring the edges of the wound together to heal. You have an open space that has to granulate in. So secondary intention healing would be like an extraction socket. Like you extract the tooth and there's just this open wound that has to fill in. Does that make sense?
Yes, thank you.
Yep. Number 7, which of the following is not considered periodontal surgery? So yeah, Lafort, I'm not cutting people's jaws apart and detaching their maxilla. But the other 3 are certainly things we talked about periodontal wise. I hope they weren't all like A. I think they were supposed to be mixed up. They're just, anyway. Sorry.
No, they were mixed up. They were mixed up. Answer key. It just defaults back to A.
Okay. I'm like, oh my gosh. Okay. That would have been annoying to me, but okay. So gingivectomy may be used to eliminate supragingival pockets. So I'm sorry, supra bony pockets. So that was true. So if you remember when we talked about gingivectomy, if there's a bony aspect to it, if there's a bony defect, then just simply doing gingivectomy isn't going to resolve the pocket, because there's an aspect of that pocket that's intra-bony into the bone. Which of the following is not considered a main incision type in modified Widman? So the 3, remember, are you start with the internal bevel, then you do your sulcular, and then your perpendicular. So the external bevel is the opposite of the internal as far as your angulation. So that's just something that you'll just to remember, I guess. But external is opposite of internal. Which incision would you not use during gingivectomy if you're simply trying to remove excess tissue? So if you remember, if there's a bunch of excess gingival tissue, we're typically going to do that external bevel, which is up and away from the sulcus, and we're just cutting away, excising excessive tissue. The internal bevel is angled down towards the alveolar bone and is removing a small layer of right along the free gingival margin, and that in the sulcular lining, essentially, on an internal level. So if I'm going to use internal bevel, I'm going to use external. Which area of the mouth is an apically positioned flap not possible? So obviously, the one difference is the palate. And if you remember, the reason we can't do an apically positioned flap on the palate is all the tissue there is connected, is keratinized tissue and attached tissue. So you can't necessarily manipulate that tissue palate on the palate to apically position it. Bone architecture. So when we're doing osteosurgery, if you remember, we're trying to achieve positive architecture. Occasionally it's flat. Negative is not good. So negative architecture essentially means that the bone on the buccal surface or lingual surface of the tooth is more coronal than the interproximal bone. And that's essentially going to lead to pocketing, because you've got the bone in the buccal and on the buccal surface is essentially propping the gingiva up, and with the loss of bone interproximally, your probe's going to drop in further. So if we can lower that bone and become more flat or positive, where positive being our interproximal bone levels are higher than our buccal or lingual bone levels, then we typically see a better result and less probing depth. So we want to avoid negative architecture. We're trying to fix that. Which of the following bone graft materials consists of bone obtained from different species? So again, xenograft would be that. So it could be bovine, it could be equine, lots of different types. Autograft, okay, same person, same patient. Alloplast is a artificial graft material, so tricalcium, phosphate, different things like that. And then an allograft is graft material from the same species. Which of the following characteristics of a bone defect will lead to the worst likelihood of success? So this one could be a little confusing just because I know we talked about like wide defects are less likely to be grafted than a shallow defect. However, you know, a one wall defect we talked about is really not very graftable at all just because there's no walls essentially left to contain your graft. So going to be a really hard graft to do. But I could see if you said wide, that's a little less predictable than a shallow, but worst likelihood, one wall defect, no containing the graft. Which of the following is not necessary in periodontal regeneration? So we talked about we need to have bone, PDL, and cementum to have regeneration, and enamel is not necessarily part of the periodontium, so that's not going to be part of that. This is true or false. The main goal of mucogingival surgery is the creation or widening of mucosa around teeth or implants, so that's false. We want to have the creation or widening of keratinized attached tissue around teeth or implants. So we want less mucosa, more keratinized tissue. What benefits may be seen with a wide zone of attached gingiva? So the answer would be improved aesthetics. So typically we find it more aesthetic to see gingiva and attached tissue around the teeth, whereas that, you know, the other two are opposite. So typically if we have a wide attached gingiva, we tend to see less inflammation and better plaque removal with more attached gingiva. Miller classification of recession. So what classification is the recession above the mucogingival junction and no bone or interproximal tissue loss? So that's class 1. So that's the one we like to see if we're going to treat it. Class 2 is simply the recession is at or below the mucogingival junction and no interproximal bone loss. Class 3 is at or to the mucogingival junction, but you also have an aspect of tooth rotation or some interproximal loss. And class 4 is widespread bone loss and attachment loss in multiple teeth and in interproximal areas. Which of the following is not a common healing stage in a free gingival graft? So ossification, there's no bone formation happening here with the free gingival graft. So if you remember, you have plasmatic circulation, which is the first step where you're getting essentially osmosis or diffusion of nutrients. Okay. Then you start to see revascularization, meaning blood vessels begin to grow into the graft and proliferate throughout the graft. And then functional integration is when the graft actually is integrated into the surrounding tissue. Number 20, which of the following is a contraindication for immediate load of an implant? So if they're a heavy bruxer, that's something that you really need to be cautious of. But again, protected occlusion, meaning there's teeth essentially on the mesial and distal of the implant, which can be used to take the brunt of the occlusion. You get good insertion torque is a good indication to load an implant, and no bone grafting needed is also a good indication for an immediate loaded implant. So bruxism is something that you want to be careful with on that. Any questions on those? Those are kind of similar to what you'll see on the test, essentially.
I had a question about the Miller classification.
I think those are,
sure.
are very indicative of,
oh.
Sorry, go ahead, Olivia.
The Miller?
Yeah, I think
sure.
it was 17.
Right there.
So when we're answering this question, is it always in reference to the mandible? Because when I was answering it, I was thinking of it in reference to the maxilla.
Yeah. So this is the age-old above, below. Which way are you looking at? So I should have. That's a good question. It should be coronal. Would be a better way to put that. So it's for any tooth.
Okay, thank you.
Sorry, that's a good question and a good clarification. It's just simply meaning above would be coronal.
Got it. Thanks.
Yeah, no problem.
So my question, maybe this isn't really an accurate question. I thought these 20 questions did a good job of sort of covering the material we were over. But when I think that the final exam is 60, so 3 times that, can we just expect more questions on these same topics? Or like where are the other sort of 2/3 of the questions going to come from?
It'll be from the lectures. So it'll be essentially like this, but there'll be, I mean, there's a lot there. Yeah, I mean, I wrote the questions from my portions based on what I had in my lecture. So you should be able to lecture and answer the question, essentially. Does that make sense? That's what everyone says, right? So, but
that's
I
totally
tried.
fair. I felt these questions were indicative of what we covered. My thought was just like, I feel like this did a pretty good overview of the things we were over. And then the idea that, there's gonna be 3 times as many, does that mean that we're looking at much finer details? Just to try to generate questions from the same lecture.
Yeah, I don't, that's my intent. Like I tried to write these like I wrote the others. So now obviously there's always going to be like some that maybe you have a problem with or whatever. I understand that. But like I tried to be like, I tried to use it as if I read the lecture, I could answer the questions, that were on the test. Does that make sense?
Yeah,
that's probably what everyone says, but that's what I tried to do. So please don't hate me. We'll work it out.
Does it also include questions from today's lecture?
Yeah, so the question, there'll be some questions from this lecture we did. Yep.
So I had a question.
Yeah.
Someone else speaking or?
No, you're good. Go.
About the last question.
Uh-huh.
I tried asking a question about this during that lecture that we had on this topic, but I guess I didn't do a really good job of asking it, so I'm gonna try again. But for
well, I'll try and do a good job of answering.
No, I think I didn't know how to ask it, but
Okay.
For immediate loading of an implant, could we say that one of the other contraindications of that is an implant that was placed immediately? Because most of the time, wouldn't that need a bone graft, or could we?
Okay. Yeah, I remember kind of having this question, this conversation. So, yeah, so you can. Yes, most immediate implants, we do essentially a socket graft around them, right? So like, let me start here. When I'm doing an immediate placement of an implant, I'm only gonna place an immediate implant if I have a nice, clean socket. So I've got all the walls, there's a buckle plate, and it's all intact, okay? So then I'm gonna place my implant. Now, typically your implant diameter is going to be smaller than the tooth you took out, right? So like a number 8, that's a fairly good size root. And if I place like a 4 millimeter implant, like a pretty normal diameter, I'm going to have space around that implant in the socket, right? Does that make sense? There's going to be air. Yeah. So my bone graft is essentially going to be in the socket, just around it, just like pushing it down around the implant in the socket. That bone graft to me is different than like placing an implant, which then needs a buccal graft because I have a dehiscence in the buccal bone and I'm trying to regrow a bunch of bone that's been lost. Okay. So like I could have been better at explaining that is like that bone graft is indicative to me of not immediately loading. Whereas if I immediately place the implant, I have a good socket and everything's intact and I've torqued it in. That bone graft is contained by bony walls, and a temporary crown may even help me contain that graft by having my the convexity of the crown to kind of hold the graft under the gingiva, right? Because your struggle with that is you got to have a way to contain that graft once you put it into the socket, right? Does that make sense? Or else it just washes out.
Yeah.
So you can do some sutures to kind of pull the gingiva down over it with the healing abutment and things. But an immediate crown on that may actually, with the contour of that crown coming up and out towards the buccal, may contain some of that graft. So I guess I would clarify that it may depend on the type of bone graft you're doing. Because if you're grafting an immediate socket, like immediate placement, that graft is much more containable because you essentially have a 3-wall defect and everything's kind of contained in there. Does that make sense?
Yeah, that makes sense. And that's what I was wondering about. I was like, if you have a good socket where you have bone all the way around and you're able to torque that implant into the bone really well, like what's stopping you from doing an immediate loading of the implant?
And I could have explained that better.
No, again, I think it was just me just thinking of the question but not knowing how to ask it.
No, that's good.
And for that immediate loading, is that a temporary restoration or could you put the definitive restoration on there?
Most people will do a temporary just because you can, the idea with like an immediate placement or immediate placement plus an immediate loading is that you can shape the gingiva by adding to or taking away from that crown. And so you place your crown and you say, okay, it's growing, my gingiva is a little too high. I can add to the crown and make it a little more bulbous and that'll push the gingiva down. Or I can take away from the crown, make it more straight and that gingiva should grow up and over it. So typically I think people you want to do a temporary because you can adjust that. And once you have the gingiva to the contour you like, then you can make your final crown to mimic that. I'm sure there are people that do like a final restoration, but it's a lot harder to like adjust anything there.
And I think it makes more sense too because you can kind of see how it affects the gingiva and also by that, I guess.
It may be like, and it could be different in like I don't know if someone's doing like I don't know if I would immediate load a molar or something, but your aesthetics there isn't as important as something in the front, but yeah, no problem. All right. Any other questions on that stuff? I think you have a lecture at 1 with Kathleen. So she will be on at 1.
I've got a quick question.
Yeah.
I'm sure, and you've probably gotten this already, maybe I missed it, but the video that we watched yesterday with Dr. DePede on the fundamentals, there were not like slides that we were able to download. So just kind of took notes on that. Is that all on the test as well?
I did not do any questions on that. I don't think it's going to be on the test, but I would double check with Dr. Hegde. I didn't do anything for it.
Okay, I'll ask her. Thank you.
Yep.
And how many questions are you anticipating per lecture? I'm sorry, so many questions about the exam.
No, that's okay. I mean, I'd say I'd have to go back and look. I'd say the bulk of the questions would probably come from the first 2 lectures I gave you. And then this Adv Perio, there's probably only a handful. I'd have to look. I don't know right off the top of my head, but that's what I remember.
Thank you very much.
Uh-huh.
Are you the only one that wrote questions for the test, or did also Dr. Hegde?
I'm pretty sure I think it was just me.
Okay, thank you.
So, but you could ask her.
What about
I
Kathleen?
didn't see any. I don't know that she has any questions, but again, that would probably be a Dr. Hegde question.
Thank you.
I know I wrote at least 60 from my material. So she may have put a couple extra in or whatever.
Dr. Jensen, with the epithelial gingival graft, I know that we stitch back on the flap, like you essentially flap it open and take tissue out and you graft that, and then you stitch like the most outer layer back, right? So is that
with the harvest?
Yeah, with the harvest. Sorry, with the harvest. So is that is that most outer layer? Is that the keratinized part? Are we not putting keratinized tissue on with the gingival graft, or what is that tissue that we're putting on?
Yep. So we're, good question. So essentially when we're doing a connective tissue graft, when I harvest that, my goal is to harvest the connective tissue just under the epithelium. So when I am done, when I take out that graft, if you remember that picture that was on there, where oh gosh, it wasn't in the lecture, but essentially you've got like a 2 millimeter wound along the palate where I've taken that section of tissue up and out. And so everything that goes back is mostly exposed wound of connective tissue. Okay, so back to the healing, that's going to be typically some secondary healing because I kept that palate all the way back up. But so I'm trying to, my goal there is to harvest connective tissue under the epithelium of the palate. So there's one little strip of connective epithelium on my graft, but I can trim that away. Does that make sense?
Yeah, so that the epithelium, that would be like the keratinized tissue though, right? Or is
correct?
And there's not, okay. And so do you have to like make another incision to kind of separate the epithelium and the subepithelium?
Yeah, so
yeah.
Here, let me give me 1 second. Let me see if I can find something real quick. Give me 1 second. Let's see if I can find a picture of it to make it a little more clear.
I'm just trying to figure out what you stole from me my D1 year when you I mean,
hopefully you've
I'm worried about this.
Fully recovered.
Yeah, I'm great.
Let's see. I'm trying to find like a video. Oh, maybe this will work. It's interesting because everybody does it so differently. Oh boy. Oh boy, that's nice music there. Give me 1 second. Okay. So let me show you. I'm going to share this video real quick. Okay, can you see this YouTube?
Yes.
Can everybody see this?
Yes, we can.
Yes.
Can you hear me?
Yes.
Yes, we can.
Okay. Oh boy, and it's got music too. So we don't need the music, but maybe it's nice. I don't know. So you can see right here what they're doing is they've made essentially an incision along the palate here, and then they've made another one here. So there's this loose tissue in between. There's like a little section of tissue that they're cutting away.
Is that the double-bladed instrument you talked about?
No, this is just a single blade. So he's done 2 incisions with the blade, essentially. So I use one that has the double blade that does it twice. So they're doing essentially parallel incisions.
What is the double-bladed instrument called again? Sorry.
It's called the Harris knife, Harris. Okay, so here's their second. They're gonna, you know, incise behind it like they have. The mesial vertical to release the mesial portion of the graft. And then they'll do a distal vertical to release the distal. And then at the base of the graft, they have to make a horizontal incision to release the graft up and out. So you'll see them make this incision and pull the graft out.
So did those layers separate pretty easily from the keratinized layer?
Yeah, they do. I mean, with the Harris knife, it's pretty quick because I'm making 2 parallel incisions right at once. So then I just have to make that mesial and distal incision and right at the base, and it goes fairly quickly. They're like elevating a little bit. See, there's the graft. But typically it comes fairly quickly, and then they'll suture this the palate back together. But you can see, like right here, there's going to be like a little wound. See right? Oh, hold still. Right through here. Oh my heck! Making me car sick. There'll be like a 1 to 2 millimeter wound of where there may have been a little epithelium on the graft, and you can trim that away.
So then that's considered secondary attention?
That would be just slightly. Yep. So when they suture this, what they're doing is they're kind of pulling the base, they're putting pressure on it, but there's still like a little wound through there. Anyway. Does that make sense more now?
It does. Thank you.
Good. Okay. Anything else on there? You're going to do a good job. You know, just take your time, read through that stuff. And then Kathleen will be back on at 1 to go through her lecture. So send me an email if you need anything. I try to get back to you as quick as I can. So.
Thank you very much, Dr. Jensen.
Okay, no problem. Thank you. We'll talk to you later.
Thank you.